what's happened here is that this tooth has been accessed, the pain hasn't settled, then this tooth has been accessed and the pain hasn't settled. This is where the problems now start. But please screenshot this. The other term that you'll hear is Socrates. We need to look beyond the obvious, so we need a roadmap of where we're going. We also talk about the periradicular tissue, so we need diagnostic terms to describe what's going on at the apex as well as the pulse. And the only reason there would be 8 millimeters of pocketing into that furcation region in a periodontally healthy patient is because that's actually a pulpal floor perforation. This is the classic signs of vertical root fracture. Look at the occlusion. Canines are worn. Canine guidance is now on the premolar instead of the canine. You can clearly see where it's marked up with the articulating paper. The little creases across the marginal ridge, indicative of vertical root fracture, and there it is. Huge vertical root fracture, that's nearly a split tooth. So if you want a true cool test, please, the first thing that you do when you get back into the practice, whenever that is, throw out your ethyl chloride, because it's more expensive than endofrost, and it's that isolation in the air dry may give patients enough of a response. But what I'm doing here is I'm syringing in hot water. All I can say is the patient has a positive response to hot thermal changes. How am I going to reproduce that? But this is your next cheapest option, okay? So a nice little tip. Other one, illumination. This is a traumatized tooth. There may be the suggestion of periodontal widening. So please, please, please feel free to screenshot that, but have a structure of how you look at things, because accept the fact that there's a vertical root fracture and plan accordingly. Okay, so last 30 seconds, red flags. Not everything that looks like a radiolucency is periapical disease. Please be aware, please be suspicious of the unrestored teeth.